More than 13,000 women will die from ovarian cancer this year, not because there was no treatment available, not because medicine has no answer for it, because the cancer was not found in time. Here's the number that changes everything. When ovarian cancer is caught at stage 1, while it is still confined to the ovary, the 5-year survival rate is over 90%. Over 90%. When it is caught at stage 3 or stage 4, after it has spread, that number falls to somewhere between 20 and 30%. Same disease, completely different outcome. The only variable is when it was found. And here's what makes that gap so important and so preventable. The body does not stay silent during those early stages. It sends signals, consistent, measurable, documented signals that begin months, sometimes more than a year before any diagnosis. The problem is not that the signals are invisible. The problem is that they look exactly like things women are taught to dismiss: bloating, tiredness, feeling full, a little pelvic discomfort. The kinds of things a busy woman in her 50 seconds calls Tuesday. Today, I'm going to go through all 6 of them, what they actually feel like in the body, how to tell the difference between a symptom worth noting and one worth acting on, and what the research says you should do if you recognize any of them. If clear, honest health information is what you are here for, subscribe now and leave a like. It helps this channel reach the women who need this information before they need it. Let's get into it. Chapter 2. Why ovarian cancer is missed. The system problem. Before we go through the 6 signs, I want to explain something that most people do not know. And once you understand it, everything else in this video makes more sense. There is no routine screening test for ovarian cancer. None. For breast cancer, there is a mammogram. For cervical cancer, there is a pap smear. For colon cancer, there is a colonoscopy. These are imperfect tests, but they exist. They are scheduled. They catch things early because the system is designed to look. For ovarian cancer, there is no equivalent. The CA-125 blood test, which measures a protein sometimes elevated in ovarian cancer, is not recommended for routine screening in women without symptoms. It produces too many false positives and too many false negatives to function as a reliable population-level tool. What that means in practical terms is this: the only early detection system available for ovarian cancer is you. Your awareness of your own body, your knowledge of which symptoms are clinically meaningful, and your willingness to report them and push for investigation before they become undeniable. That is not a criticism of medicine. It is a description of where the science currently stands. A 2023 report from the American Cancer Society confirmed that despite significant research investment, no validated screening method for early ovarian cancer detection currently exists for general use. The field is moving. Liquid biopsies and proteomics-based tests are in development, but they are not yet clinical reality, which means the conversation we are about to have is not supplementary. It is the primary detection strategy available to you right now. Chapter 3. How the symptoms work. Why they get dismissed. Before the 6 signs, one more thing that is critical to understand. Ovarian cancer symptoms in their early stages are not dramatic. They are not sharp, sudden, or unmistakable. They are the kind of symptoms that accumulate gradually, that a woman adapts to over weeks, that a physician hears and attributes to irritable bowel syndrome, perimenopause, or stress, and that the woman herself has usually already explained away twice before she even mentions them. This is documented. A 2022 study in the British Journal of General Practice found that women with ovarian cancer visited their GP an average of 3 times before being referred for investigation. 3 visits with symptoms present at every one of them, before the right question was asked. The clinical threshold that makes a symptom worth investigating is not severity. It is persistence and pattern. The research uses a specific benchmark: symptoms that are new, that occur more than 12 days per month, and that have been present for less than 12 months, meaning they are a recent change, not your lifelong normal, constitute a clinically significant pattern. Write that down if nothing else in this video lands. New. More than 12 days per month. For fewer than 12 months. That combination is what distinguishes "my body is changing" from "my body needs attention." Now, the 6 signs. Chapter 4. Sign 1. Bloating, the one everyone has. The first sign is the one that gets dismissed the most reliably by both women and their doctors. Bloating. I want to be careful here because I know what most people will think. Everyone bloats. Bloating after a heavy meal. Bloating during certain phases of the menstrual cycle. Bloating after a difficult week. That is not what we are talking about. Ovarian cancer-associated bloating has a different character. It does not follow meals. It is not relieved by bowel movements. It does not track with your cycle. It is present most days, for weeks at a time. The abdomen feels full, tight, or distended, and it stays that way. In some cases, the bloating is caused by a direct mechanism. Ascites, or the accumulation of fluid in the abdominal cavity produced by the tumor and surrounding tissue. This is a late sign. The early bloating is different. It is caused by the tumor pressing against adjacent structures, by the body's early inflammatory response, and by changes in gut motility as pelvic anatomy shifts. One pattern that clinicians use to distinguish significant bloating: it worsens across the day regardless of food intake. A woman will notice her abdomen feeling fuller by late afternoon even after eating very little. Waistbands that fit in the morning become uncomfortable by evening. These are not dramatic changes, they are consistent ones. A 2023 analysis of symptom data from women diagnosed with ovarian cancer found that bloating was present in 72% of cases, and that the average time between first noticing it and seeking evaluation was 4 months. 4 months. Not because these women were careless, because everything around them told them this was normal. Chapter 5. Sign 2. Pelvic or abdominal pain. The second sign is pain in the pelvis or lower abdomen, not severe pain, not the kind of pain that sends you to an emergency room. A dull, persistent ache, a pressure, a heaviness, something that feels like mild cramps that never fully resolve. It can be intermittent, present for a few days, easing off, returning. Or it can be a low-level constant that a woman learns to carry without noticing it anymore. The anatomical reason for this pain is straightforward. The ovaries sit in the pelvis on either side of the uterus. As a tumor develops, it puts pressure on the surrounding pelvic structures, the bladder, the bowel, the pelvic floor musculature. That pressure is felt as a dull discomfort that is difficult to localize precisely and easy to attribute to any number of other causes. In women over 50, this symptom is particularly vulnerable to dismissal. Postmenopausal women are often told that some degree of pelvic discomfort is a normal consequence of hormonal change and tissue changes after menopause. Premenopausal women may attribute it to menstrual-related discomfort. The clinical distinction is this: normal menstrual-related pelvic pain has a clear cycle-linked pattern. It comes, it goes, it follows a schedule. Ovarian cancer-related pelvic discomfort does not follow a schedule. It is present between periods. It is present after menopause. It persists when menstrual causes should be absent. If you have had pelvic or lower abdominal discomfort for more than 3 to 4 weeks that does not have a clear cyclical or dietary explanation, that is worth raising with your doctor. Not alarming? Raising. Chapter 6. Sign 3. Feeling full quickly. Early satiety. The third sign has a clinical name: early satiety. It means feeling full after eating significantly less food than usual. This is not a loss of appetite in the way people typically describe it. It is not nausea. It is not a deliberate reduction in eating. It is sitting down to a meal you would normally finish and finding that after a few bites, you feel full, uncomfortably full, as if there is no room. The mechanism is direct: a growing ovarian tumor, particularly one that is developing fluid or increasing in size, reduces the physical space available in the abdominal cavity. The stomach, which sits above the reproductive organs, has less room to expand. Meals that would previously have been comfortable become meals the body physically cannot accommodate. This symptom often travels with the bloating. A woman notices she is eating less, feeling full faster, and also noticing her abdomen looks or feels distended, and she concludes she has developed some kind of digestive sensitivity. She eliminates foods, she tries different eating patterns. The symptom does not respond to dietary changes because its cause is not dietary. The research from MD Anderson Cancer Center describes early satiety as one of the 5 most common presenting symptoms in ovarian cancer, alongside bloating, pelvic pain, urinary changes, and fatigue. Their clinical framework uses the acronym BEACH: bloating, eating difficulties, abdominal pain, changes in urination or bowel habits, and hunger loss. 5 specific trackable symptoms. Together, they form a pattern that is clinically distinct from functional bowel disorders. Chapter 7. Sign 4. Urinary urgency or frequency. The fourth sign is a change in urinary habits, specifically needing to urinate more frequently or more urgently than before, without an increase in fluid intake. This symptom is among the most commonly misattributed in this age group. In women over 50, urinary frequency and urgency are almost universally attributed to a weakening pelvic floor, to the effects of menopause on bladder tissue, or to early bladder control issues. These are real and common conditions, which is exactly why this symptom gets lost. The distinction matters. Pelvic floor-related urinary changes tend to be stress-related. They worsen with physical exertion, coughing, or laughing. Menopausal bladder changes tend to be gradual and steady over years. Ovarian cancer-related urinary changes have a different pattern. They develop over weeks to months. They are not stress-linked. The urgency is not provoked by movement. It is present at rest. A woman who previously never needed to get up at night now wakes twice. A woman who could comfortably wait now cannot. The anatomical explanation is the same as for the pelvic pain. The growing tumor presses against the bladder wall, reducing its functional capacity. Less space means the bladder signals fullness earlier. More frequent signaling means more frequent urination. This is a symptom that women particularly tend to not mention to their doctors. It feels private. It feels like the kind of thing they should manage, not report. Please report it. In the context of the other signs, it is one of the most useful pieces of information a clinician can have. Chapter 8. Sign 5. Persistent fatigue. The fifth sign is fatigue. And I want to address immediately why this is one of the hardest symptoms to take seriously in yourself and in clinical practice. Fatigue is the most commonly reported symptom in primary care medicine. It is associated with dozens of conditions, with sleep disorders, with depression, with thyroid dysfunction, with anemia, with the ordinary demands of a demanding life. A physician who sees fatigue in a woman in her 50 seconds or 60 seconds has a very long list of possible causes before ovarian cancer appears on it. But cancer-related fatigue has characteristics that separate it from ordinary tiredness. It does not improve predictably with rest. A full night of sleep does not resolve it. It is present in the morning before the day has asked anything of the body. It has a heaviness that is qualitatively different from tiredness after exertion. The biological mechanism connects directly to the cancer's activity. Tumors are metabolically demanding. They compete with normal tissue for glucose and nutrients. They trigger an inflammatory cascade. Cytokines, interleukins, and other signaling molecules that the immune system releases in response to abnormal cell growth. And this systemic inflammatory state is directly fatiguing at a cellular level. It is not tiredness from doing too much. It is tiredness from the body fighting something it has not told you about yet. Critically, cancer-related fatigue tends to worsen over time. Ordinary tiredness fluctuates. A woman with ovarian cancer may notice that her energy level 3 months ago was better than it is today, and that the decline has been slow and steady rather than event-linked. That trajectory is the signal, not one tired day. A progressively lower baseline over months. Chapter 9. Sign 6. Back pain and bowel changes. The sixth sign is actually two connected presentations that often appear together: persistent lower back pain and changes in bowel habits. The lower back pain associated with early ovarian cancer is dull, located in the lumbar region, and does not have a clear musculoskeletal cause. There is no specific movement that aggravates it. There is no injury history. It does not respond to usual interventions, rest, stretching, anti-inflammatories, in the way mechanical back pain does. Its cause is pressure from a growing pelvic mass on the nerves and structures of the lower back, combined with referred pain from pelvic organ involvement. The bowel changes can include new constipation, increased frequency, or a persistent change in stool character. Not a single episode, but a sustained shift from the individual's normal pattern over weeks. Both of these symptoms share the same problem as the others. In women over 50, lower back pain and bowel habit changes are so common that they generate almost no alarm. They are attributed to posture, to diet, to the natural changes of aging. And for most women, most of the time, that attribution is correct, but the combination changes the calculation. Lower back pain plus bloating, bowel changes plus early satiety, pelvic discomfort plus urinary urgency. When two or more of these symptoms are present simultaneously and have been present for more than 2 weeks, the research is unambiguous. The appropriate next step is a clinical evaluation, not continued watchful waiting. If clear information like this matters to you, subscribe now. Every person who subscribes helps this channel reach one more woman who needs it. Chapter 10. The pattern that matters. When signs combine. This is the chapter I most want you to remember. Individual symptoms, each evaluated in isolation, rarely trigger the right clinical response. Any single one of the 6 signs we covered today can be plausibly explained by a dozen other conditions. A doctor hearing about bloating alone, or fatigue alone, or pelvic discomfort alone is working with insufficient information. The pattern is the signal. 2 or more of these symptoms, present simultaneously, persisting for more than 12 days per month, representing a change from your previous normal, that combination is clinically meaningful in a way that no single symptom is. A landmark paper in the British Medical Journal established what is now called the Symptom Index for ovarian cancer. The index identified 6 core symptoms and found that their combination, rather than any individual symptom, had a sensitivity of 57% and a specificity of 87% for detecting early-stage ovarian cancer in symptomatic women, specific enough to be clinically actionable. 57% sensitivity means the symptom index will not catch every case. But for a disease with no screening test, a 57% sensitivity rate in women who report these symptoms is a significant detection opportunity, one that is currently being missed because the symptoms are not being reported, not being recorded together, and not being evaluated as a pattern. Here is a case from the gynecologic oncology literature that illustrates this exactly. A woman in her late 50s, referred to in the clinical record as Patricia, had experienced intermittent bloating and a gradual decrease in appetite for approximately 6 months. She had seen her family physician twice in that period. Both times, the symptoms were attributed to irritable bowel syndrome and age-related digestive changes. No pelvic examination was performed at either visit. No symptom pattern was documented. When she returned a third time, mentioning now that she was also experiencing urinary frequency and some lower back discomfort, her physician ordered a pelvic ultrasound. The mass found was 8 centimeters. The cancer was stage 3. The symptoms had been present for 6 months. The pattern was there. It was not assembled. Chapter 11. What your doctor needs to hear. How to report these symptoms. If you recognize any of the 6 signs in yourself, the single most important thing you can do is go to your doctor and report them as a pattern, not as individual complaints. Do not say, "I have been a bit bloated." Say, "I have had persistent abdominal bloating on most days for the past 8 weeks. It does not improve with dietary changes. I am also eating less than usual because I feel full quickly, and I have had more urinary urgency in the past 6 weeks." That framing changes everything. You are reporting a symptom cluster. You are quantifying duration. You are describing what has and has not relieved the symptoms. You are connecting signs that individually seem minor, but together constitute a pattern a physician can act on. Bring a written list if it helps. Write down the symptom, when it started, how often it occurs, and what you have already tried. Physicians are trained to evaluate symptoms that are reported this way. They are not always trained to ask the probing follow-up questions that surface this information organically in a short appointment. You are not being a difficult patient. You are giving a clinician the information they need to do their job. The appropriate initial investigation for the symptom cluster includes a pelvic examination, a CA-125 blood test, with the understanding that an elevated result requires further investigation and a normal result does not rule out cancer, and a transvaginal or pelvic ultrasound. That is the starting point, not a final answer, a starting point. Chapter 12. Risk Factors. Who is at higher risk? Understanding your individual risk profile is not about fear. It is about calibrating your attentiveness to symptoms appropriately. The factors that meaningfully increase ovarian cancer risk are well established. Age is the primary risk factor. The majority of ovarian cancer diagnoses occur in women over 50. The median age at diagnosis is 63. Risk increases steadily across the 5th, 6th, and 7th decades of life. Family history carries significant weight. Women with a first-degree relative, mother, sister, daughter, diagnosed with ovarian or breast cancer have a substantially elevated risk. The BRCA1 and BRCA2 gene mutations, which are most commonly associated with breast cancer, also dramatically increase lifetime ovarian cancer risk, up to 44% for BRCA1 and up to 17% for BRCA2 carriers. Women who have never been pregnant have a higher baseline risk than women who have had children. Each pregnancy reduces cumulative ovulation, a factor associated with lower ovarian cancer risk. Endometriosis, a condition in which tissue similar to the uterine lining grows outside the uterus, is associated with a 2 to 3 times higher risk of certain ovarian cancer subtypes, specifically clear cell and endometrioid carcinomas. Hormone replacement therapy using estrogen alone, without progestogen, in women who have had a hysterectomy has been associated with modestly elevated risk over long-term use. Higher risk does not mean certain diagnosis. It means the symptoms we covered today deserve faster, more decisive clinical follow-up. It means you do not wait 3 months to see whether the bloating resolves. You report it now. Chapter 13, What Does Not Increase Risk? Clearing the Myths. There are persistent misconceptions about ovarian cancer risk that are worth addressing directly. Talcum powder. The association between talc use in the perineal area and ovarian cancer has been a subject of litigation and significant media coverage. The current position of the scientific literature is that the evidence does not establish a causal relationship. Major review analyses, including a 2023 study in JAMA examining over 250,000 women, found no statistically significant increase in ovarian cancer risk with talc use. Fertility treatments. The data on fertility medications and ovarian cancer risk is similarly inconclusive. Long-term studies have not established a consistent causal link between ovarian stimulation treatments and ovarian cancer development. Diet. While certain dietary patterns are associated with overall cancer risk, no specific food or dietary pattern has been established as a direct cause of ovarian cancer. I mention these because fear-based health content often creates misplaced concern about factors that do not carry meaningful clinical weight, while simultaneously normalizing the symptoms that do. The 6 signs I described today matter. A specific brand of body powder does not. Spend your attention on what the evidence actually supports. Chapter 14, Protective Factors. What reduces risk? The same evidence base that identifies risk factors also identifies factors associated with reduced risk. These are worth knowing because they give the picture balance, and because some of them are actionable. Oral contraceptive use over 5 or more years is associated with a 40 to 50% reduction in ovarian cancer risk. This protective effect persists for decades after stopping. This is one of the strongest and most consistent findings in the ovarian cancer epidemiology literature. Breastfeeding is associated with modest risk reduction, with longer cumulative duration producing stronger protective effect. Tubal ligation, surgical closure of the fallopian tubes, reduces ovarian cancer risk by approximately 30%. The mechanism relates to the close anatomical relationship between the fallopian tubes and the ovary and to the role that tubal origin cells may play in certain ovarian cancer subtypes. Salpingectomy, removal of the fallopian tubes, has an even stronger protective effect and is now being discussed as a risk reduction strategy for women undergoing other pelvic surgery for unrelated reasons. Maintaining a healthy body weight reduces overall cancer risk, including ovarian cancer risk. The mechanisms involve reducing systemic inflammation and modulating circulating estrogen levels. These are not guarantees, they are modifiers. Risk reduction is not risk elimination, which is why knowing the symptoms remains the most important information in this video, regardless of your risk profile. Chapter 15, The Diagnostic Pathway. What happens next? I want to briefly walk through what happens after you report these symptoms so that the process does not feel opaque or frightening. Your physician will begin with a physical examination, including a pelvic exam to assess for any mass or irregularity. They will order a CA-125 blood test. It is important to understand that CA-125 is not a definitive diagnostic test. It is elevated in only 50% of early-stage ovarian cancers, and it can be elevated by many other conditions, including endometriosis, fibroids, and even menstruation. A normal CA-125 does not rule out ovarian cancer. An elevated CA-125 requires further investigation. The next step is typically a transvaginal ultrasound, an imaging test that can identify ovarian masses, their size, and some characteristics of their appearance. If an abnormal finding is present, further imaging such as CT or MRI may follow. If imaging raises concern, referral to a gynecologic oncologist, a specialist in cancers of the female reproductive system, is the appropriate pathway. Biopsy and definitive diagnosis occur in that specialist setting. This process moves faster when you report symptoms as a pattern and persist if your initial concern is dismissed. You are entitled to a second opinion. You are entitled to ask why a referral is or is not being made. Advocating for your own investigation is not an overreaction. For a disease with no screening test, it is the only early detection strategy that works. Chapter 16: Age and Timing. When this conversation is most important. Everything in this video applies across adult life, but the stakes are highest in your 50 seconds and 60 seconds. After menopause, symptoms that might previously have been attributed to menstrual-related causes have lost that explanation. Pelvic discomfort, bloating, and urinary changes that develop after menopause have fewer benign explanations. And ovarian cancer risk is climbing steadily across these decades. The median age of ovarian cancer diagnosis is 63. That means the preclinical symptomatic phase of the disease, the phase when these 6 signs are present but diagnosis has not yet occurred, is happening in women who are largely in their mid to late 50 seconds. If you are in that age range right now, this video is speaking directly to the highest risk window of your life for this disease. How old are you? Write it in the comments. It helps me understand who is watching, and it helps shape what I cover next so that it is directly relevant to where you are. Chapter 17: Action Steps. Here is what we covered today. When ovarian cancer is caught at stage 1, the 5-year survival rate is over 90%. When it is caught late, that number falls below 30%. The difference between those two outcomes is almost entirely determined by when the symptoms are reported. There is no routine screening test for ovarian cancer. Your body is the detection system, which means knowing these 6 signs is not optional information. It is the primary early detection strategy available right now. The 6 signs: 1. Persistent bloating that does not follow meals, does not respond to dietary changes, and is present most days for weeks. 2. Pelvic or abdominal pain that is dull, persistent, and not cycle-linked or event-linked. 3. Feeling full quickly after eating, or eating noticeably less than usual without intending to. 4. Urinary urgency or frequency that represents a change from your normal, not explained by fluid intake or physical exertion. 5. Persistent fatigue that does not improve with rest and has been gradually worsening over months. 6. Lower back pain without a mechanical cause, and changes in bowel habits that represent a new pattern sustained over weeks. The threshold for action is not severity. It is persistence and pattern. Any 2 or more of these symptoms, present on more than 12 days per month, for more than 2 to 3 weeks, representing a change from your normal, report them as a pattern to your doctor. Quantify them. Bring a written list if it helps. Request a pelvic examination, a CA-125, and an ultrasound. Do not wait to see if they resolve. For this disease, waiting is the most dangerous choice available. If this gave you something you needed today, please subscribe and leave a like. And please share this video. The woman who needs it most may be someone you love, and she may not know to look for it. Everything in this video is for educational purposes only. Every woman's health picture is different. Please discuss these symptoms with a qualified healthcare provider. Do not use this video as a substitute for medical evaluation.